So, what did I just say? Today we're going to cover the small bowel. Next week we're going to cover the large bowel. Okay. Alright, so the small bowel series. The purpose of the small bowel series is to study the small intestine. As I had said last week, it generally follows the upper GI series. There will be some times where the doctor will order a combination of esophagram, upper GI, and also a small bowel series that all kind of is done together. It does require oral contrast media. So with that said, if we're looking at a small bowel, what do you think a contraindication is? I mean, I'm just jumping ahead. What do you think a contraindication would be? It's going to be just like what? The upper GI. So talking about perforation, blockage, what else? Is there anything else? Recent surgery, pre-surgery. Pre-surgery in that, you know, if they are going to have some kind of abdominal surgery, you want to, they want to schedule that barium exam so that there is enough time to evacuate the contents. Another one would be, it's not so much of a contraindication, but before you perform a study like this, again, you want to double check and make sure that the other departments are performing some type of procedure in which the barium will get in the way of their study. All right, you guys remember your quadrants? 4 quadrants: right upper, right lower, left lower. So when we break up the small bowel, it's broken up into 3 segments. You have your duodenum, jejunum, and then your ileum. And if you break them down into your 4 different quadrants, the duodenum is found in the right upper quadrant and the left upper quadrant. Very, very short segment. The second segment here is the jejunum, which is generally found on the left side and also central. It says here left upper quadrant and left lower quadrant. Left side. Then we have the third segment is the ileum, found in the lower quadrants of the right and left, and also included in the right upper quadrant. Are you guys familiar with the term ileocecal?
Wow.
Okay, so that is referring to the union between the small bowel and the large bowel, the cecum of the large bowel. So ileocecal region or the valve is located at the right lower quadrant. Okay, any questions so far? All right. So the duodenum is going to be the shortest segment, about 10 inches in length. It forms that C loop. So it forms a C, comes back up. It's held by the ligament of Treitz. Then the next one here is the jejunum, 2/5 of the small bowel. And then, now what happens here is as you're going from the duodenum to the jejunum, to the ileum, the diameter of it gets more, narrow and narrow. Okay, so it goes from wide to narrow. Okay, so the ileum is going to be the longest segment, but it's also going to be the narrowest of the segments. Now, radiographically, are they easily identifiable? And that would be a yes. But first of all, if you understand the quadrants, that will help you locate where the different segments of the small bowel is going to be, where they're going to be and how they look. So again, the duodenum is going to be the larger in diameter. It's also the shortest, but it's right off of the stomach, and it's easily identifiable because it forms a C. Now the jejunum, they have a feathery appearance to them, a feathery appearance. So if you look at here, it has a feathery appearance to it, or they say it looks like coiled spring or stacked coins is another way that they describe it. And then if you look at the ileum, they have little indentations to them that look very similar to that of a large bowel, but it's smaller. So they have the small indentations on the edges of them. Okay. And again, if we did an entire study of the abdomen, we know this is a small bowel because it's centralized. Large bowel is in the periphery. Now, the way a small bowel study works is that we do them in segments or times, sequential time images. Let's just go ahead and jump forward. Okay, so here is the area, the ileocecal area, where the small bowel communicates with the large bowel. And this, you can see the difference in size. Very, very narrow, very small, and then the part of the large bowel is larger in diameter. And that is the part where there's a tendency for that area to telescope. What is that term called?
Twist.
No, not twisting, that's volvulus.
Oh,
Intussusception. Okay, so this is where intussusception generally occurs because of the differences in their size. I uploaded you guys the latest version a couple of hours ago. So the changes that I have on here, you guys have the latest version too, up on Canvas. Okay.
Cool, thanks.
All right. Okay, so if you're looking at this again, A, to identify A, first segment of the small bowel, it should duodenum, duodenum. Then you have the feathery appearance. This is the jejunum, and then if you look at the small indentations of the bowel, this is the ileum. Okay. So the movements of the digestive tract in the small intestine, the contents are moved by peristalsis, wave-like contractions, or rhythmic segmentations. This is localized contractions in areas that contain food. Localized contractions. So this is important because if we lack peristalsis, if you don't have that ability to move the contents throughout the bowels, they just sit there. And so now you have an obstruction. Okay, so this is important, trying to get those contents through the small bowel and then into the large bowel. So a summary of the lower digestive system functions. We'll talk about the small intestine today. We'll talk about the large bowel next week. But the purpose, first is digestion. So we have chemical digestion. We also have mechanical digestion. That's your peristalsis and rhythmic segmentation. Absorption of the nutrients, water, salts, and proteins, and then reabsorption of water back into the system. And so this is primarily where the absorption occurs, is in the duodenum and the jejunum, is where a majority of the absorption occurs. All right, so let's begin talking about the small bowel series. The purpose is to study the form and function of the small bowel. The small bowel procedures can, again, either follow an upper GI. It can be a standalone, just a standalone small bowel series. Or we have a special type, we have two special types of small bowel series which necessitates putting in some kind of tube into the stomach and into the duodenum. And that would be enteroplices and then the intubation method. So we perform enteroplices, which is and I'll get to this again later on, but it's a double contrast study. Generally, small bowel series, there is just single contrast. But in this case of enteroplices, we'll do a double contrast study. And what do I mean by double contrast? It's going to be air and barium, okay? And we generally do this with Crohn's disease, sprue, and ileus. And the other intubation method will be the small bowel enema. Again, it's like an NG tube or a nasogastric or a nasoenteric tube that will be inserted down into the proximal area of the small bowel. So, same contraindications. Pre-surgical patients, if there's any suspicion of a perforation, and then also any type of obstruction, Doesn't matter if it's large, if it's small, if there's suspicion of an obstruction, it's a contraindication. So if barium is contraindicated, then we're going to use water-soluble contrast. Remember, barium is not soluble, so it's got nowhere to go. It's a metallic substance. So we don't want to put anything that's undigestible into the patient's body because you can cause a lot of problems. And then here, if this is contraindicated, then we're going to use iodine. Iodine is absorbable, water-soluble, and but the contraindications for iodine would be dehydration. Iodine is a diuretic. We mentioned that last week. So you don't want to give that to anybody who is who's already dehydrated. You don't want to give it to the young. And also, again, this is questionable, but again, we'll stick to what the book says, but sensitivity to iodine may also be a contraindication. Why would we do a small bowel series? Well, we have enteritis or gastroenteritis. We're going to go through these individually. Neoplasms, malabsorption syndromes, ileus, giardiasis, Meckel's diverticulum, and also Crohn's disease. So here we have a radiograph of someone who is experiencing an ileus, and you can see that there is this distension or dilation of the small bowel, and there's also a thinning of the lining of the walls of the small intestine. So it looks very painful, right? Yeah, you can generally tell someone who may have a small bowel obstruction by the distension of their abdomen. Just a note there somewhere. When we're talking about ileus, and we'll talk about this later on, just if you can just write this down because I might forget later. For an ileus, you cannot see fluid levels on an ileus in an upright position. You cannot see fluid levels of an ileus in an upright position. Okay, so Meckel's diverticulum, it's the most common congenital abnormality. It occurs in the connection, when the connection between the intestine of the baby and the umbilical cord doesn't completely close. Okay, so that's your Meckel's. Then we have the malabsorption syndrome, also known as sprui. It is the inability to absorb proteins and fat caused by intraluminal defects, mucosal abnormality, or the lymphatic system itself. And radiographically, the mucosal lining appears to thicken. Types of sprui, there are many types. The first one here is Whipple's disease. It's a rare bacterial infection that often affects not just the digestive system, but is systemic. It also infects your central nervous system, your cardiovascular system, your joints, so it's systemic. The other one here is celiac disease. Celiac disease, you've heard of those who are lactose intolerant, are gluten intolerant, who are sugar intolerant. Those are all different forms of celiac disease. So Whipple's disease, again, we have mucosal thickening of the walls. Okay, Crohn's disease. Crohn's disease is a chronic inflammatory disease. That means it's constantly thickened, constantly inflammatory. They have no cure for Crohn's. It's also known as regional enteritis or segmental enteritis. And so those who have chronic inflammation of a particular segment, if they're not able to control it, they have to remove that section of the bowel and then join the other ends together. And it is a common occurrence near the terminal ileum. So again, we're talking about the distal part of the small bowel. Okay? So it's most common in that site. In advanced cases, the segments of the intestine become narrow due to chronic spasm and it has that string sign. Here what we have up here is the cobblestone appearance. So they have two different types of appearances. One of them looks like cobblestone. The other one looks like this. They look like strings. So this is a string sign. This is a string sign. String sign. String sign. And again, if Crohn's disease, if left untreated, or in worst cases of Crohn's disease, it can lead to obstruction. Fistulas. Fistulas is basically an opening. So you'll have openings caused by Crohn's. Fistula also is not just an opening, but it can communicate with other parts of the body. You may have a fistula that may communicate from the small bowel into a large bowel segment, and now there's a communication between the small and large bowel. That's also a fistula. Okay, and then lastly, an abscess formation. Giardiasis. Giardiasis is an infection of the lumen due to flagellate protozoan, spread by contaminated food and water. So radiographic presentation, it's dilation of the intestines and with thickened circular folds. I've never seen one of those in my lifetime. I don't know if you guys will either, but hookworms. You guys didn't have that in your old slide. I just added this now. So there's your hookworms. So hookworms, I was trying to find a really good picture. The ones that I found were kind of, it'll kind of literally make you sick to your stomach if you saw it. So that's something that was a little bit more rated G. Yeah. So hookworms. Hookworms, see, you can see this filling defects here. So these are all hookworms in the what is this? This is the ileum. So the filling defects, you can see the squiggly lines in there. So how do you get hookworms? From contaminated soil or dirt. So, you know, if you get contaminated dirt in your mouth, I mean, kids do that all the time, right? It's possible that they can get hookworms. And the hookworms comes from fecal material of animals. So you get fecal material on the dirt, you touch the dirt, you touch your mouth, and it's generally accidental. That's how you can get hookworms. Okay, ileus. Ileus is probably what you're going to be seeing most of the time in a radiology department, and why we would do a small bowel series. So an ileus is an obstruction or disruption of the normal propulsive ability of the gastrointestinal tract. There are two different kinds. You have mechanical, which is a physical obstruction caused by, for example, tumors, adhesions, hernias. And then you have paralytic. Paralytic is caused by peritonitis, appendicitis, drugs, and also post-surgical complications. And paralytic is when the small bowel loses its ability for peristalsis and also rhythmic segmentation. In other words, the bowel doesn't move, so the contents get stuck, causing an obstruction. And again, you have an X-ray here showing the distended loops of the small bowel. Here's another ileus. That one looks like it hurts. All right, any questions? So let's go ahead and start talking about the position for the small bowel. First of all, patient preparation. If this is accompanied with an upper GI, same concept applies. They're NPO, 8 hours before, no gum chewing, no smoking, make sure they're not pregnant. Okay? How do we get them dressed for a small bowel? How do we get them dressed or undressed?
Just have gown on and that's
So
it.
again, we're looking at this area over here, so just remove everything from the waist up. Okay? Yeah, that's about it. They can leave their underwear on. But if there's bra, I would remove the bra, especially if the patient may be hyperstenic, everything gets pushed up, and now you got the bra, the underwiring, and maybe what do you call that, the clasp showing up on the X-ray. Any type of body jewelry. Don't have your patients wear pants. Sometimes I've seen technologists do these studies with the patient's pants on. Don't do that, because now you have buttons and zippers getting in the way. Room preparation, we're going to do fluoroscopy. Fluoroscopic and radiographic imaging should be ready to go. Before we do fluoroscopy, we're going to get into this later on, but remember the bucky here. Whenever you guys are getting ready to use the fluoroscopic tower, you want to make sure that this is slid all the way down at the end, because once the X-ray starts shooting up, now you're generating scattered radiation all over the place. So you want to make sure that bucky is slid all the way down at the end of the table. So we have fluoroscopy and radiographic imaging equipment, contrast media, your image receptors, and if we're doing any type of catheter type of procedures, have your enteroplices or NG tubes available. What you're also going to need here is timed markers. Do you guys, see, I'm old school, so you guys are going to have to educate me on this. Do you guys have timed markers? They're like your lead markers, but there's times on there.
They have them, but everyone just annotates everything.
So everyone just annotates everything, okay. All right, so before you make the image final, you want to make sure that you are annotating then the times of the x-rays that you take. I'm going to explain this later on, okay? Also make reading material available. Again, this will make sense here in just a little bit. Now, I went back to review the slides that I presented to you guys last week, and it looked like there were some slides that were missing. So I'm going to share that with you right now. I had a situation between last year and now where part of my data got corrupted, and so the part that got corrupted, so I'm going to share with you now, is when you are doing any type of fluoroscopic procedure. Anytime you're doing a fluoroscopic procedure, you guys writing this down? Anytime you do a fluoroscopic procedure, you need to take a scout film. A scout film. It's a preliminary film. Preliminary film. So the scout film just lets us know that the patient has been properly prepared for the procedure, and it also helps us identify any type of anomaly before the patient ingests contrast. Because if there's anomalies in there and they drink the contrast, we no longer see that anomaly. Okay, so we want to see it prior to the patient ingesting the contrast. So again, the scout film is done to make sure that the patient has been prepped properly and to identify any type of anomalies before they ingest the contrast. Because again, once the contrast is there, it'll hide it. Okay, so that's what the scout film is for. Now, for an esophagram, the scout film is, what do you think it is?
like chest X-ray.
A chest X-ray. Okay, so the scout film for an esophagram is a chest X-ray. So this is the way it goes. And again, I wasn't able to explain this to you guys last week because I lost my visual cues. They weren't up there. All right, so you bring the patient into the room. You take their history. You have them undress. Okay? They come out. You're still having a conversation with them. So now you're going to do a chest X-ray. The chest X-ray is going to be presented to the radiologist. So before you do anything, you're going to present the scout image to the doctor. share the history with the doctor. And then the doctor will say, go ahead and proceed. And what they mean by go ahead and proceed is go ahead and get them on the table or on the standing version of the table, and then get them ready, go up on the table, have them give them the cup of their contrast, and then you call the radiologist in to perform their esophagram. Okay? But all that is done before you call the doctor in to perform his study. Okay? Now, that's the esophagram. Now, what about an upper GI? What do you think the scout film is there? What are we doing there?
Abdominal.
Okay, yeah. It's a KUB. You guys know how to do KUBs now, right? Okay. Now, it's slightly different from the KUB that you know. It's the same, but instead of centering at the crest, we're centering a little bit higher. So it's going to be about 1.5 inches to 2 inches above the crest for your scout for an upper GI. 1.5 inches to 2 inches above the crest. Because the stomach is up here, it's in the upper abdomen. So we're going to do a high KUB.
So when you say we're centering 2 inches, you're talking about central ray or cassette?
The central ray.
Central ray.
Central ray. Because when you do a KUB, it's at the crest.
Okay.
Okay? So a scout for an upper GI, you're going to go 2 inches above the crest because we want to get more of the stomach on there. Okay? So now you would show that image to the radiologist, share the history with that radiologist, and then the next thing they're going to say is, go ahead and start the study. Okay? Now again, we're just talking about the upper GI. So once the doctor says, go ahead and begin the study, you go into the room to get your patient ready for an upper GI. What is your prep to begin the upper GI? This is all review from last week. So before you put them on the table for an upper GI, what are you going to give them?
Barium and crystal.
Okay, you guys remember that? A little cup of crystal, a little cup of barium. Okay? You're going to give them the crystals. Throw in the back of your throat. Give them the contrast. Throw that in the back of the throat and they swallow it. And again, you got to remind them not to burp when they swallow it. Then what's the next thing you're going to do? Before you call the doctor in, what are you going to do? Okay. So you're going to get them on the table now. Now we want to coat them. So they're going to lay on their back, on their side, on their belly, on the other side. We're coating it up. And we do that anywhere between 2 to 3 times. It's not just one rotation. It's about 2 to 3 rotations. And now you get on the phone and call the doctor and say, we're ready for you. Yes?
What if someone can't roll around?
You roll them though.
You want me to show you what we do? No, we massage your stomach.
Switch it around?
Yeah, we do our best. We have them, so if they can't roll around, this is actually a very, very good question. If they can't roll around, RPO, LPO, tilt the table up a little bit, tilt the table down a little bit. You get it? Yeah, so the table can help us do that. And that's, again, a very, very good question because you may have somebody who's an inpatient that can't move for you. So now how are you going to coat their stomach? That's how you would do it. Okay? So now you call the doctor in and then you begin the procedure. I actually I was talking to Mr. Benoya when I saw him a couple of days ago, and he said that in his facility they never did overheads after the fluoro part of it. They never did it. So the doctor only did the fluoroscopic part, and they were done. But he did say he did end up working somewhere else where they did fluoro overheads. Young, weren't you were talking about a barium enema? What was it the other day?
Yeah.
Yeah. So Young was saying that in their department they did the fluoro part of it, and then they did their overheads. Now, how many overheads do you have to do for a barium enema?
Like
5. We did 9.
That was a lot.
Yeah, that's a lot. While the patient had a tube up their
She was
butt.
very uncomfortable.
Yeah, it's a very uncomfortable procedure. So you guys did 5. We used to do 9. And I also asked that of Mr. Benoit, and he says, no, he goes, we never did overheads for barium enema. So again, it differs from hospital to hospital. All right, so the doctor comes in and does the procedure, and now this is where we are. Now, quick question. If the patient came in for both an esophagram, I shouldn't say both, I'm going to give it a little twist. If they came in for an esophagram and an upper GI, yes, esophagram, upper GI, how many scouts do you do? How many scouts do you do for esophagram and an upper GI? You still have to do a chest, you still have to do a high KUB. Okay? Now what if the patient came in for an esophagram, an upper GI, and a small bowel? It's still 2. Still 2. It's a chest x-ray, it's an abdomen. Yes?
So the scout for a small bowel is still high?
It's still going to be high.
Okay.
Yep. But don't quote me on that. We've already talked about variations from place to place. Places that I've worked has always been a high KUB. So I'm again sharing my experience with you. You may end up in a hospital saying, no, don't do a high KUB, you should be a low KUB, just a regular KUB. But it's still two scouts, one for the esophagram, one for the abdomen. Okay? All right. Any questions so far? So these are all the things that you'll need in your department to get ready for the small bowel. This is something new. I think I showed that to you guys last week, the compression paddle. So have a compression paddle. Sometimes the floor towel will have its own compression paddle built underneath. Towels, napkins, lead aprons. Make sure that footboard is locked in place in case they need to tilt the table up. This is kind of a bad example because they don't have a floorboard, so I don't think they have any intention in standing the table up. But it doesn't hurt to just make sure it's in place and locked in place in case they do stand it up. Okay? Tower curtain. We have tower curtain in the back room, right?
Mm-hmm.
Okay, tower curtain. So that protects the doctor and the technologist from scatter radiation. Slide the bucket all the way down. You need your time markers. If you don't have time markers, then be ready to annotate your images. Positioning sponges, and again, reading material. Reading material can mean, you know, a magazine, or it can be your iPad, or it can be your phone. Just something that they can keep busy in between their pictures. And again, this is going to make sense here in just a moment. So the first one that we're going to discuss here is the upper GI small bowel combination. Upper GI small bowel combination. So after the upper GI has been completed, the small bowel series part of it is going to begin. It actually began the moment that they drank that contrast agent, that first cup of contrast agent during the upper GI. Okay? So the upper GI is just not just giving a small swig of crystals and the barium. They're going to be drinking some contrast also during the procedure. It's usually a cup like so. It's about 8 ounces that they're going to finish during the upper GI study. Okay? You guys follow so far? So again, it's just not the little cups that we give them. They will be drinking a cup of barium during the procedure. It's about 8 ounces. So after you've completed the upper GI, recall the positions of the upper GI. What are the positions? We have REO,
LPO,
LPO,
APPA, lateral.
AP, PA, and then a right lateral. So there's five overheads that you have to do. Recall that one of the projections that you do is a PA. Okay, you guys recall that, okay? So when you're done with your series, remember that that PA that you did for the upper GI study, just keep in mind that that's also going to be part of the small bowel series. So The routine upper GI study is done and completed first with the routine overhead views. Keep in mind, make a notation when they started drinking that cup of barium during the upper GI study. Make notation of when they drank that first cup of barium during the upper GI series. Okay. Now, when you're done with the upper GI, and now you begin the second part of the exam, the small bowel series. After you've taken your upper GI overheads, you're going to sit your patient up, and now you're going to give them a second cup of barium. Their second 8-ounce cup, and they're going to drink that. Okay, you guys follow? All right, so I'm going to backtrack a little bit. Upper GI, you finish the upper GI, and part of the upper GI that you've done is a PA-KUB, a prone KUB, okay? Then you're going to sit them up to drink the second cup of contrast. Then you're going to lay them down, and now you're going to take your second KUB in a PA projection. So, let me see if I can write this down. So the way this works here is that all right. So in upper GI, I'm going to write on top of the clock. So during the upper GI, your first KUB that you took, okay, we're going to call that 15 minutes. This is going to be your 15-minute KUB. A PA KUB. Prone, okay? And then what they're going to do here now is they're going to drink their second cup. Drinking their second cup. Okay? And by the time they're done drinking their second cup, because trust me, you can't guzzle barium. So it's going to take them a while to drink that barium. So by the time they're done drinking the barium, you're going to lay them back on their belly again. And now you're going to take your second KUB. Okay, this is 15 minutes later. Is that hard to see, guys?
Yes.
Okay, well, I'm not going to erase it. Just kind of, here, maybe if I do this.
Second. Good choice.
Is that working?
Yeah.
Okay. You know why I don't choose red? I don't see it. I barely see it because of my color blindness. All right.